We do have 10 minutes to continue this conversation as a larger group, and so I'd like to take the opportunity now to ask at least a few of you to bring up the example or some issue of substance that was raised at your table. If there's a group in the satellite room that would like to come in and contribute to this, I just want to mention that please come to the room here. There's a microphone set up so that we can have folks from the satellite room as well. So who'd like to kick us off with an observation or example? Okay, go ahead.
We had a good discussion about the personal liberties, and the example we'd like to share is all of us probably in our relative professions teach non-judgmental kinds of behaviors in professionalism. And yet, when you look at the topics we've had here around social accountability, health disparities, health equity, and all of that, that we may or may not be acting in the way because it is a personal liberty in a sense that you do give up by not being judgmental. However, we question whether or not that it really occurs.
Others? Go ahead.
I've been voluntold to give my example by
voluntold? I just wanted to make sure I heard the word.
Who follow me. We had a very short discussion about the changing of the taxonomy of personal liberties to self-identity. And then I took up the rest of the 5 minutes, so I apologize to my group, because the story I told was about having to change from being a lawyer to becoming a physician, and then actually to becoming a decanal appointee. And Ken called that code switching, but I learned how to adjust my personal liberties or my identity, and to a certain extent actually to fake it in order to adhere to the requirements of the profession or the role that I was playing, and in order to meet those promises and oversight. So I think the question that we were grappling with was, to what extent do we actually get people to pretend to do those things?
That's terrific, and I have to admit, the Cruces and I had a conversation about this at breakfast, and I left personal liberty in here specifically to be provocative. But I think you're right. What we're talking about here is less a matter of personal liberties on the order of right to bear arms or whatever, and more along the order of how I think about myself.
One quick comment.
Yeah, please.
The educational psychologists and sociologists who study identity formation,
Yeah.
Sarita said she pretended, but the assumption is that repeated pretending leads to the incorporation of those beliefs and values.
Yeah, that's it. So I think Cynthia mentioned that earlier as well. Yes.
So this is an interesting discussion, in part because the IOM to is Human report really sort of was a bucket of cold water in the public's face in terms of 100,000 people a year dying essentially from medical mistakes. And Jim Reinertson, who was the former head of the Park Nicollet Clinic in Minnesota, had this to say, which I think is really good. He suggests that the way through this individual professionalism issue is a Zen-like paradox. To regain control of patient care decisions, physicians need to relinquish it to their colleagues. To preserve their autonomy, they must first give it up to the systems they create and the science and the evidence they endorse. So when you get together with a collection of your colleagues because there's sufficient evidence that says you need to have standing orders in the hospital regarding this kind of protocol or that kind of protocol, you are in fact giving up that individual liberty, shall we say, to the collective, which has more wisdom than you do as an individual. So it's absolutely fascinating, but it is in fact the IOM report that sort of started us down this road 13 years ago.
Yeah, I love the Zen-like paradox.
Yes.
This is something I've actually written about quite a lot. the Zen-like paradox that in order to acquire professional autonomy in the sense of the right to make decisions with patients that are right for that individual patient, we have to give up some of our individual right to do that kind of thing to the group to establish practice standards.
He wrote this article in the Annals of Internal Medicine in 2003 in response to the report, and the title of it is The Zen of Maintaining Physician Autonomy, I think, something like that.
Beautiful. George?
A similar theme came up at our table, in that we acknowledge, or want to, I believe, that every practitioner is in fact attempting to make the best decisions at all time within the knowledge that they have and that the profession has. Having said that, we all know that the limitation of our knowledge, the interpretation of the data that are out there, and the gaps in that knowledge that exist, mean that each of us at times makes decisions that are not the best. And only if we subject those decisions to review or to a group process could we maximize the benefit of those decisions, even though the individual decision was always made according to the best ethical and professional principles. It still can be improved upon.
Maddie?
We came up with 4 quick examples of this tension. The first was around religious beliefs and the choice of declining to provide care around certain situations. Second one was free speech and our promise of confidentiality. The third was risking our own health, and the example that came up was early HIV/AIDS care. And finally, financial gain and the ways we use over-treatment to promote personal financial gain at the risk of our patients.
I'm glad someone got to the classics, because there are some classic conscience issues in medicine that in bioethics, we talk about all the time. And I'll just make one quick point on the HIV/AIDS issue, because this makes, I think, a nice segue into the next thing we're going to be talking about, which is the role of the public in establishing professional standards. In the early mid-1980s, when the AMA came out with its first ethical standard with regard to caring for patients with HIV infection, some of you will probably remember this. The first statement of the AMA with regard to AIDS was, doctors have a responsibility to care for patients with AIDS unless they are emotionally incapable of doing so. Right. And this was in 1986, June. And there were about 200 editorials written about this in newspapers around the country, and there was a backlash within both outside and inside the profession. And within a year, this was changed. And now it's just doctors shall take care of patients with HIV infection, period, full stop. This, I think, is a really nice example of what I've called the social construction of medical ethics. So we think we write our own code of ethics without input from others. But in fact, if we write it wrong, we will hear about it. And so there's, I think, a good deal, and I think it's fair, by the way, because there are many ways in which we should be criticized and we should be more open in the development process of ethical standards and practice standards within medicine. But the reality is these eventually become publicly declared standards. And at that point, they are subject to criticism by the public and by individual patients. And eventually, the way this hashes itself out is we come to a social contract that has, in fact, been, in some ways, signed on both sides, even if it started with a document created by one party to the contract. So that's where we're headed next. I am afraid we are supposed to move on. I hate to do that, but I'm going to move us on. So let's just put the question back up and give you one more shot to vote on this one. We'll do this very quickly just to see in the end if anyone had an epiphany during your conversations. Okay, and I think we'll move on. I think that's pretty close to what we saw before, isn't it? No epiphanies, dang. Okay, moving on. Professionalism and its alternatives. So a couple slides about this. And again, I'm not going to go into great detail. There are sociologists in the room. I'm well aware of this. I'm speaking outside my realm of expertise. But the understanding of professionalism in the context of other ways of thinking about organizing medical work is relevant to this conversation. So Talcott Parsons, the structural functionalist growing out of Max Weber and his school, importantly saw professions as serving a social function. And so they looked at professions and said, what's unique about professions and what social function does that unique aspect serve? So professions tend to keep confidential the information given to them by their clients. Why? What's the social function of that? And it's easy to think about this in terms of medicine. You know, if someone tells you about their sexually transmitted disease, you need that information to treat them effectively, to prevent them from passing it along to others. So there's a socially useful function of confidentiality as a trademark of professions, right? One of the things they had to deal with is, remember, this is the era of Adam Smith. So they had to think about, and Parsons did think about, why would it be that professionals would not merely look out for their self-interest at the expense of their clientele? And what he said, and I apologize, I'm just the messenger, he said, psychologically distinguished people go into the professions. They're distinguished in the following way. Most people are just out for themselves. That's how they get benefit. That's what most brings them utility. Professionals, what most brings them utility is looking good in front of their peers. So it's not the case that professionals are not out for their own self-interest. They are. Their self-interest is in looking good in front of their peers. That's who tends to go into the professions. So this was their hypothesis, and it was widely admired, especially among professionals, until the 60s, when many such hypotheses were re-questioned. And so if you think about the critical, or what are called the power theorists, and this includes people like Eliot Friedson and Paul Starr, who look at data and say, you know, that all sounds good, but in fact, professionals are out for their own self-interest, and too often it's financial and privileged self-interest, not the interest in looking good in front of their peers. So professionalism is about collecting professional prerogatives through a collective pursuit of high status, and even a willingness to make promises without the ability or capacity to keep them. So this led to a rethinking of professionalism as a way to organize delivery of goods and services in society. And it's just worth bearing in mind that professionalism is not the only way to think about delivering goods and services, right? Consumerism is an alternative to professionalism. Consumerism has quality assurance through competition, right? One pizza parlor here, another pizza parlor here, you get good information, and you compare the two, and the bad one goes out of business and the good one stays open and spreads. It emphasizes transparency in its ethics. It optimizes value with regard to resource allocation. Value, by the way, as defined by willingness to pay on the part of individual consumers. And it treats healthcare as a normal good, just like toothbrushes and motorcycles and everything else. Socialism is another way to think about organizing healthcare or any other social good, right? Regulatory mechanisms, equity is the primary emphasis of ethics. The idea here is to try to optimize overall social benefit, and it treats healthcare as a common good, like military protection of the community or environmental protections. And professionalism is an alternative to these three. So it assures quality ostensibly through collegial review, not through primarily regulatory or competitive mechanisms, right? We have fiduciary obligations that are the core of our ethics, putting the patient's interests first. We balance individual and social needs. This gets back to the point about how do we garner the trust of individual patients and of the community as a whole. So we have issues around, patients who come to ask us to do stuff that we actually can't do, even though it might benefit them. I cannot write you a letter to get you out of an airline ticket unless medically that's justified. Not because you wouldn't get benefit from me writing you a letter. It's because I have a contract with not only you as an individual, but with the community as a whole. So we balance these. Talcott Parsons called professions an interstitial go-between, between the needs and wants and desires of individuals and the desires, wants, and needs of the community. And our original code of ethics for the AMA actually was very explicit about this. It had a chapter on the patient's responsibility to doctors and doctors' responsibility to patients. It had a chapter on doctors' responsibility to the community and the community's responsibility to doctors. It was all about reciprocity, very contractual in nature. So the reality, of course, and this won't come as a shock to any of you, is that we use all three of these mechanisms in the real world. We don't organize, no healthcare system uses one at the exclusion of the others. And in fact, they blend together. So a very high success profession is one where professional standards are built into the state regulatory mechanisms. So what's the difference now between state regulatory mechanisms and professional self-regulation? They get blurry. That's a hallmark, in fact, of a successful profession, I would say. So this is what we're talking about in the end, is a balancing act. And that's the next question that we want to discuss at the tables, is this balancing act. What is the role of the public, of regulation, of markets in professional regulatory mechanisms and in ensuring quality? Oh, sorry, this is just a really nice quote from Eliot Friedson, who was one of the original critical power theorists, and towards the end of his career really came around to the notion that, in fact, turning the professions over to regulatory or market mechanisms as the primary method of delivering services was a great risk. And in fact, despite the flaws of the professions and their ability to self-regulate, it was better than the alternatives. I leave that to you for discussion at the tables. So here's the discussion question. How should state regulation, market competition, and writ large, these are ways in which the public influences professional standard setting and practice. So how does the public, and you can think about an example to share. Okay, so we have 5 minutes for conversation. Time. Okay. Your 5 minutes, I'm afraid, are up. So now that you've ironed that out, let's continue this conversation as a group. And I'll just ask for, go ahead. Can you come to the microphone though? Because there are folks in the satellite room who will want to be able to hear. That was a question. Can you get to the microphone?
You know, I work in the fields of complementary and alternative and now integrative medicine, and you know, the role of markets has changed everything. So when the word came out in '93 that there was $13.8 billion being spent out of pocket, and that a third of people were using some of these services, it was very interesting because at that moment, hospitals began to say, well, let's start offering it. The evidence hadn't changed. Medical schools began to look at it. Insurers began to offer, employers began to add it to benefits packages, and that it was not an evidence shift, it was simply market coming in. And I think it's been a good force there. And it limited the ability at that moment of the professions to, they began to have more flexibility with their members and their ability to practice outside of norms. Once there was this awareness that the consumer kind of liked it, or a certain subset of it. So.
Yes.
So we talked about the situation within federal services like the Indian Health Service and Malcolm's World, where based on the needs of the health system at a local area and their use of privileging and credentialing processes locally, what a particular state regulation may say a given practitioner can or can't do may in fact be superseded by the local needs and the professional practice standards of that institution.
Yeah, we're touching both of these on issues of what is called professional closure, the idea of establishing the set of rules. I think Fred talked about this as well, the set of rules about who gets to do what, and what's going to be reimbursed and for whom. And these are, I think, broadly speaking, issues where the professions have a tremendous stake, but they don't make the final decisions. In fact, society decides whether, and society is a pretty big word, doesn't mean anything in particular sometimes, but social norms and regulatory and legal mechanisms are how society decides who gets to do what. So, you know, issues around scope of practice and other manifestations of professional closure are social conversations. They're not just professional conversations.
Could I just make a comment? When the physician charter was first published, there was huge pushback by the profession saying, we can't do these things because the society is not organized in a way that permits it to happen, or certainly that encourages it to happen. I think it was a vivid example of how this set of issues is very, very critical for the ability of the health professions to really behave professionally.
Yeah, and this is, you know, it was about the same time that the charter was being developed that that we first brought together the what was called the Ethical Force Program. But the idea was to think about the environment, the infrastructure. What is it about the healthcare system that could make it easier, or that is making it harder for individual practitioners and groups of practitioners to live up to the professional standards that we were articulating or wanted to articulate, but felt we couldn't because, in fact, we can't tell people. There's an is-ought dilemma in philosophy. You guys remember this? Undergrad philosophy. So you can't tell someone that they have to do something that they cannot, in fact, do. It can't be unethical to do something which you cannot accomplish. or to not do something. Sorry, too many negatives. Who's next? Go ahead, George.
So we talked a little bit about the impingement of the political process and the real live example today of Medicaid expansion, where the profession doesn't get to decide whether poor people in one state will get health care coverage or they won't. The political process will decide. So we live in a world in which our professional desire is limited by the political process, and that's a reality.
Yes.
I think it's interesting to note that state regulation and market competition represents the public word or the public voice in how it affects the professional practice standards. But what's missing in that is the patient's voice. So it's a voice of the common good, so to speak, but it's gotten way out of balance between what it is that the patient needs and wants in whatever circumstance that they're in. And also another thing that was noted at this table too is that state regulation is so variable. The 50 states can do all kinds of things with nursing practice acts that are very variable, and it places a great deal of confusion in the hands of consumers and other disciplines.
Yeah, and that's, I guess, not unique to the United States entirely, but it is, it's an interesting feature of the U.S. regulatory scheme. I intended the word state in a broader sense as in governmental regulation. So it could be state, could be county, could be city, could be. Yeah, Sally.
So I think reinforcing a bit of the previous comment, our table reacted a bit to your replacing state regulation and market competition or equating that to the public, and feeling a bit that that seemed a little disingenuous, that possibly some of the state regulatory issues related to practice have more to do with the influencing of the organizations, the professional organizations themselves, and their ability to lobby for what they want, versus what the public might even understand about what they're trying to lobby for, and that the market competition isn't necessarily a fair market in healthcare, particularly when we think about patients and their vulnerabilities, but also the public in general. I mean, we don't have a sense of how much something costs and what we should expect it to be. So I think the replication of those two themes with the word public seemed a little bit loaded on our perspective, and we felt like there's almost an opportunity for a new voice, and that voice needs to be collective and include those people that would be underrepresented normally. So.
Yeah, and this is actually the point, I think, of having this conversation, to me at least, is to think through, so what is, and that's, I'm so glad we're making really nice segues from one section to the next. Because the question here is, what is a legitimate way to establish professional standards for practice and shared values and so on that incorporates the voice of the public and individual patients and so on, right? Because what we've got right now, by all accounts, seems not to be working that well. And yet it's hard to picture something immediately that's better than the messy representative democracy we've got, right? So if we want to make a different regulatory mechanism, how is that different regulatory mechanism going to be different than representative democracy, which is what we have right now?
Just very briefly, it's interesting that you've just come to the conclusion that the first recommendation of the recent Macy Foundation was to form a new partnership between patients and professionals, or communities and professionals. And then we went into all the other sort of highlight issues. But that was put as the first recommendation because it was by far the most important one, a new voice that wasn't just this current dysfunctional chaos of voices that we're hearing, which are largely lobbyists.
Yeah, and it's a terrific question. How does one create such a thing? And how does one prevent it from becoming what we've got right now? I mean, after all, this is in some ways what representative democracy looks like. It's interest groups, it's, you know, loud people, it's vested interests. Yeah, Rick.
Yeah, it's just reminiscent of Rogers' life cycle of a cause. Always starts with a crusade and ends in bureaucracy.
Yeah. Go ahead, yeah.
We'll talk a little bit about this afternoon, but don't we have to change the discourse? Don't we have to try and the terms we use are negotiate a social contract that supports the ideal of professionalism and try and set up conditions under which we can do that? It's not easy, but certainly the current discourse doesn't include the value systems that we think the public wants. It isn't just what we want.
So we'll do two more, and then we'll move to the last question. Go ahead.
As between the three, those being market, what's consumerism, socialism, and professionalism, I have placed no hope in the market because there isn't really a market that's purely consumer. The consumers can be competent in, right? Because the market's controlled like crazy, and because it's a market the consumers aren't skilled to know how to buy in, even if they had choice. So that's one thing. To me, as a patient, I place more value certainly in professionalism and in socialism, I would, right? I mean, to me, the best way to get there is socialism, because I think the definitions of what the goals are, right, which is the greatest good for society and sort of balancing the good of society and individuals, seems like a valuable mission for healthcare as opposed to generating healthcare at a profit, right? But the main thing for me is, you asked the question a minute ago about how do you get the new discourse, how do you open to a new voice? In the musical and the story Annie, Daddy Warbucks is in the unfortunate position of having to invite FDR over for dinner because he hopes he's going to help him find his lost Annie. And he turns to his butler and says, "What do Democrats eat anyway?" And I think we would do well to ask the patients, what is the discourse patients would like to be engaged in, and not to have a conversation essentially among professionals about what patients would want.
Okay, so we're moving to the excellent comment. So we'll move to the last. Oh, sorry, we're going to put the question back up briefly. This will go very fast because you've all seen this question already. This is our epiphany check. Go. I'm going to say that's time. We'll show the results. Now we have no one on either of the first two categories. Okay, moving on. So let's just say a couple things about the arguments for professionalism, and I think we've already, as the last commenter articulated, there are some intuitive reasons, frankly, why people turn to professionalism rather than markets or, for that matter, state-based regulatory mechanisms. And these are, roughly speaking, lumped in two categories. There are those who think that there are natural professions, which is to say there are certain types of work which by their very nature must eventually generate a professional body and professional values and so on. And these are marked by a clientele who are vulnerable in some way, complex work that evolves over time. This is why professionals practice. They don't work, they practice. They're always practicing, always trying to get better at what they do because it's a constantly evolving and very complicated work product and therefore not amenable to state-based regulatory schemes. And then there are social arguments around professionalism. So these are folks who basically say, well, look, we could choose the others, but we in fact have chosen professionalism and people now rely on it. So this is an argument of reliance, which is sort of a legalistic argument. But the idea is people believe in surveys, for example, that if they get sick during an epidemic, health professionals will still be at the hospital to take care of them. Because we have made this collective promise over time that if there's an epidemic, we will continue to show up for work. This is one of the issues that you guys brought up at your table earlier. So regardless which of those, I think we've already articulated some of the challenges that are faced by a profession in actually carrying out this social contract. So in actually putting together the rules and enforcing them. So here's what the ABMS had to say about the steps required for a legitimate professionalism. And if we're going to start today and in this afternoon thinking about a transdisciplinary version of this process, would we need to have a shared, iterative, public process to define, debate, make public declarations, distribute, enforce the shared set of standards and values that members of our professional group have said will govern our work? So that's going to be the last discussion question. So we'll spend 5 minutes on this, and then I fear we're out of time. So we're just going to do the 5 minutes of discussion. Then we're going to go straight to lunch, and we will pick up with the afternoon session. Well, we'll pick up first with the cruises, and then we'll have a lot of time for discussion in the afternoon. Is that correct? There will be an announcement after this 5 minutes. Yeah. Following these tabletop discussions, there will be an announcement. Okay. So this is your discussion topic. people keeping time now. So this is your 4-minute warning, but I've been voluntold to be the one to tell you that we're gonna spend about 5 minutes now doing report back, because we feel like it's important to get a little bit of yeah, we feel like it's important to get a little bit of feedback on this. So let's go to the tables. We'll do just a couple or three burning comments on the assumption there are a couple or three burning comments. Boom, boom, boom. That's what it took. Okay. Are there folks who have something that their group talked about that is so important to get in front of the group that it merits not going to lunch yet? Yes.
Well, on that basis, no. You know, where our conversation got is that we do think there are some fundamental expectations the public should have in their interactions with any person who is involved in their care, such as introduce them by name and identify their role in this scenario, irrespective. That would begin the conversation about a shared social contract from the perspective of the public.
Very important. Yeah.
Just an observation that that we didn't have total agreement on, and actually we had examples on both sides. But I expressed the observation that you can't have a shared social contract that then parenthetically says for all health professionals. It has to be a shared social contract with society. And it might be society's expectations of the health professions, which was set. However, then we had a very cogent observation that during some disruptions in Malawi, that it was the American healthcare workers that stayed to take care of the patients where the local community left, which would be an example of health professions having a shared social contract.
Well, here at our table, we objected to the word social contract and thought it should be an explicit shared value system or belief system that, between all the health professionals, because the contracts will vary depending on the context in which you are. And the first, I guess, key that we thought we had to find out what the public needed, wanted, and expected before we drew up our own values and behaviors.
Yeah. Interesting that you would be the one to question the social contract. I have to say, I've often been a little uncomfortable with the term contract. I usually use the term compact or covenant. These are a little fuzzier to me, and so I'm a little more comfortable with them. But yeah.
We came to pretty much an agreement with some of the other expressions, which is we need to do this, but we need to move beyond it and engage patients and families and communities in the dialogue about what that looks like, because right now we're still building on this assumption that of vulnerability patients can be poor consumers, but the nature of who those folks are and what they know has been changed by social media. And so the dialogue needs to be more an open one, because this idea is still a kind of patriarchal idea that we're protectionist.
We also made the observation at the table that we in this country have no existing forum that can really serve as a venue for this kind of dialogue, whereas other countries, UK, Denmark, for example, have already structured interactions between the profession and government, profession and the public in that sense, where there is real teeth to what they do.
Very interesting. Sure.
The other countries have negotiating tables because they have national health plans.
Right.
The minute you institute, and we know this in Canada from experience, the minute you institute a national health system, You must set up a negotiating table. There must be somebody designated to represent medicine, and in general, where we are, the provincial governments represent society. And it's the long time in a national healthcare system coming here that has made you once again unique.
We're special in our own special way. I think with that, we'll break for lunch. And Patricia, some comments first?
First, can we get a round of applause for Matt Winia, Cynthia Villar, and all of the morning session speakers? First announcement is we're going to be picking up the clickers, so if you could leave them on your table in an obvious place so we can make sure that we pick them all up. We'll be revisiting the clickers tomorrow. Right now, lunch is right outside. We have until about 1:15 for lunch, and then we're going to go into our small group sessions. Now, the small groups, each one of the people at the table, the members and alternates, you've been assigned a room, and it's behind tab 5, and there's a map back there as well, so you can see which room you've been assigned to. Speakers, participants, you're welcome to join any of the groups that interest you up to the capacity of the room. Once the room is filled, we ask you to find another one. The accountability and leadership will meet right in this room. So if you're in that group, feel free to stay where you are. The economic and physical infrastructure, that will be in room 204. And Melissa Simon, could you raise your hand and wave? If you're lost, look for Melissa. She'll be going to room 204. There's also going to be staff directing people around. 204 is one flight up. The patient and community group is in room 101. Is Rachel here? Rachel will be helping out with that group, and that's just around the corner. And then there's health and well-being. That's in room 202. Is Sunny in the room? Sunny's going to be helping out, one flight up. Room 202 for health and wellness. Enjoy your lunch, and about 1:15, if you could mosey into the breakout groups, I appreciate it. Thanks much. Bye.